Hi everyone. Hi, good evening everyone. I welcome you all to Unacademy and I'm Dr. Saurabh Dixit. So I'll be teaching you surgery. Before that, let us have a view of this important information. So we have iconic subscription where you get dual advantage of Prep Ladder and an academy at same platform without paying something extra. Hi Dr. Aditya. Hi. So please do enroll yourself for the NEET PG Combat. Must give exam for all of you. So please enroll yourself for NEET PG Combat. And I hope you know about the special class features that we have. So if you have still not registered yourself for the special class, yes, do log in and use the code surgery live. Remember, we have the question bank which have been upgraded, and now we have 25,000 plus MCQs. Yeah. So Shilpi is asking a very old question now. Shilpi, so does it really make difference where I'm teaching? I'm teaching with you. I'm with my students. So hardly it makes a difference where we are. So we have a very good result this year in Unacademy, and I think Unacademy is going to hit the top cloud 9 very soon. Okay. So let us start with this flashcard based, you can say, approach to this subject. So I'm going to show you a lot of flashcards. Hello Ashish, hello. Shilpi, don't worry, I'm there with you. So even if not there with the previous institute, but I'm there with you, my students will never miss me. So a newborn presents with excessive drooling of saliva with choking on feed. Following is the pathology shown in the image. Can you tell me what we are dealing with? Yeah. Hi Prince. Hi. How are you? Hello Ashutosh. Hello everyone. Hello Aku Panchal. Yeah. Great. This is a tracheoesophageal fistula. Awesome. What kind of tracheoesophageal fistula is this? Yeah. What kind of TEF is this? How do you come to know that this is a tracheoesophageal fistula? This is the trachea. This is the trachea. This is the esophagus. So we have trachea, we have esophagus, and remember, what is this? There's a blind end to one pouch of esophagus. There's a pouch of esophagus. There is blind end to the proximal end, and this is the distal, which is going and merging. So actually, this is a type C. This is a type C. Is that clear or no? Or you can say this is a distal TEF. So this is a distal tracheoesophageal fistula. Is that clear or no? So those who are saying it is type 2, it is not type 2, it is type C basically. वो older configuration होता था. अभी हम older configuration नहीं use करते. We use the new configuration which is saying that it is a type C. We'll discuss this, don't worry. What are the lesions? Is it associated with? Yes, it is associated. Good evening Adarsh, good evening. Yeah. Abhishek, yes. Good night, Abhishek. Good night. Okay. Abhishek is a new student. Yes, we should all welcome Abhishek. So let us try to understand these concepts. Just give me a minute. Okay. So let us try to understand the concept of tracheoesophageal fistula. Okay. Let us talk about this. When we talk about tracheoesophageal fistula, TEF, yeah, or the concept of esophageal atresia, we have a lot of things to understand. So tracheoesophageal fistula or esophageal atresia. The first is what is it? So if we talk about the types, we have a type 1 where there is atresia, and this is not having any connection with the tracheal system. Is that clear or no? So since there is a gap between the two ends of esophagus, this is trachea, this is esophagus, this is type A. The second type is when the proximal pouch that was created is not a pouch and it is fused with the trachea. This is what is a type 2. You can say type B. So this is a proximal TEF. This is a proximal TEF and this is type B. So this is a proximal TEF. The third variety is a distal TEF. So let us, hi Saurabh, hi bache, hi. So what is a distal TEF? Let us try to understand this. What is a distal TEF? Let us see this thing. This is a distal TEF and this is what is shown in the image. So if you see the image, what is this? This is a distal type. This is a distal type. Let us try to understand this. So this is a distal TEF. Distal TEF is also the most common type. It is also known as type C. What is type D? It's both. The proximal also is fused. The proximal is also fused, and there is a fusion of the distal type, distal also. So distal plus proximal, this is a combined type. This is a type D. And then we have the type H. What is type H? The trachea is different, the esophagus is different, but there is a communication between them in the center. So this is a type H. This is a type H, or you can say type E. If we talk about the incidence, students, incidence if we talk about, it is D which is, it is C which is most common, then A, then you have E. E variety is also known as H because of its H-like configuration. So E is also known as H. Yeah. So we have E type, then we have A type, then we have B type, and then we have D. Remember, D is the least common. D is the least common and C is the most common. Now, what are the classical associations? What are the classical associations? You have to understand it is associated with vectorial group of defects. So associations, if you talk about, it is associations with vectorial group of defects. Now, what are the vectorial group of defects? Try to understand. They are associated with vertebral anomalies. Very good. Vertebral anomalies. They are associated with anorectal malformation. So we have anorectal malformations. What else? What else? It is associated with cardiac anomalies. So cardiac anomalies. What else, students? It is associated with tracheoesophageal fistulas as well as esophageal atrachas. Yeah. So TEF or maybe esophageal atrachas. Then R stands for what? Renal dysgenesis. Renal dysgenesis. Dysgenesis. Is that clear? Then what about L? Limb hypoplasia. Limb hypoplasia. So these are the classical defects that we have. Now, if you see the question, if you read the question, you have very important thing. Let us try to understand the classical presentation. What is the classical presentation? A newborn presents with excess drooling of saliva with choking on feed. Why this happens? Yeah. Why this happens? Try to understand this. Why this happens? Let me just discuss that part. So whenever we have a newborn with esophageal atrasia, what is a classic problem that the baby will have? Answer is, bache, majority of the time it is atrasia or maybe a type C tracheoesophageal fistula. So bache, the saliva will not be able to pass down, and therefore the classic keyword is excessive drooling of saliva. Excessive drooling of saliva. Are you getting this or no? So excessive drooling of saliva is the first classical presentation, and whenever you have a newborn with excessive drooling of saliva, you should always think that yes, there could be esophageal atrasia or a tracheoesophageal fistula. The second is, when you try to pass the feeding tube, it will not pass. Imagine, you initiate the feed. When you try to feed the baby, there will be aspiration of the content because this is a blind tube. So because of the aspiration of the content, what will happen? there will be sudden violent onset of cough. So sudden violent onset of cough. Onset of cough. This is very important. Now whenever there is, बच्चे vectoral, tufali try to understand. Vectoral means vertebral anomalies, anorectal malformation, cardiac anomalies, tracheoesophageal fistula or esophageal atresia, renal dysgenesis and limb defects, limb hypoplasia. अब देखो, there is sudden onset of cough. Now what will happen if there is sudden onset of cough? Try to understand. The baby will start to cry. So baby starts to cry. Now what will happen if baby starts to cry? Can you tell me what will happen? Try to understand. Majority of the time you have the type C. Ab dekho, what is going to happen? What is going to happen? Because of the aspiration of the content, yeah, there is sudden onset of cough. Now this is the stomach. You know, I know, everyone knows that here you have the diaphragm. Yeah, here you have the diaphragm. So this is how the diaphragm is. This is how the diaphragm is. When the baby cries, there will be venting of air. So the air from the trachea will enter into the stomach, and because of this, there will be gastric distension. And since there is gastric distension, what is going to happen? Students, just see, there will be upward shift of diaphragm. Can you understand? Upward shift of diaphragm will actually further increase the pulmonary resistance. Is that clear or no? So yes, there is distension and there is upward shift of diaphragm, and because of this upward shift of diaphragm, there is going to be worsening of the respiratory pattern, and the patient will develop dyspnea and respiratory distress. Are you getting this or no? Because bache, if the diaphragm goes up and it's tented off, flattening of diaphragm basically can happen. Tenting of diaphragm will happen. The patient's diaphragmatic movements are required for respiration. वो यहाँ पर नहीं होता है, and that is what is the big problem. This is how the things are going to worsen. Now let us try to understand how to approach a patient. How to approach a patient whenever we have a patient suspected of. I hope students, these things are clear to everyone. Yeah, I think these things are clear to everyone. So whenever we talk about a patient with suspected, yeah, the patient is suspected tracheoesophageal fistula or esophageal atresia. What is the first line investigation? The first line investigation is X-ray. The first line investigation is X-ray. What are you going to do in this X-ray? Yeah, you are going to X-ray with insertion of feeding tube. Insertion of feeding tube. So what you will do, you will insert a feeding tube in the, you can say, the esophagus, and you will take an X-ray. अब देखो क्या मिलेगा आपको. Suppose if this is the, you can say, the proximal pouch, and this is the feeding tube that you have inserted. First of all, there will be coiling of feeding tube. There will be coiling of feeding tube in mediastinum, point number 1. The second is you will get to see a proximal blind pouch. Yes or no? So proximal blind pouch you will get or no? Now when you get a proximal blind pouch, there are two differential diagnoses. Either it is a case of atresia or it is a case of tracheoesophageal fistula. Now how to differentiate between this tracheoesophageal fistula and atresia? The next thing is you look for the gas in the stomach. You look for the gas in the stomach. Why this is important? देखो, X-ray is the first line support that we get throughout the day. 24/7 ये available होता है. Now imagine if you get a blind tube of esophagus only and no gas in the stomach, then that is a case of atresia. But try to understand, if it is a type C fistula, which is actually the most common type, the air will manage to enter into the stomach from the trachea. So yes, if you see the gas in the stomach, if it is present, then that is a case of type C. Type C tracheoesophageal fistula. If it is absent, then you are dealing with a, you can say, a type A, or you can say atracia. बच्चे 500 रुपए में इतना ही मिलेगा. Is that clear or no? So X-rays are inefficient to confirm what are the other types of fistulas on this imaging. So remember, you will not be able to see whether it is type B, type D, or type H. Is that clear or no? So what is the investigation of choice? What is the investigation of choice for tracheoesophageal fistula? Answer is a bronchoscopy. But you have to go to the bronchus and confirm it. A bronchoscopy. Why it is a must? Why it is a must? Do you know what is a big problem? A newborn is having respiratory distress, and when a newborn is having respiratory distress and you start with that ventilation or intubation, the gas is going to enter into the trachea, and from trachea it is going to leak into the stomach. बच्चे problem वहाँ पर आती है. So why bronchoscopy? First of all, it will give you the live view of the trachea. Point number 1. So it will diagnose as soon as it sees there is a connection between the trachea and the esophagus. So diagnostic. And what else? Transient. You can say it is, even though transient, it is a therapeutic intervention also. What do you understand by this therapeutic? Even though it is transient, देखो what happens. Suppose this is the scenario. That you are seeing. Yeah, this is the scenario that you are seeing. Try to understand. Now, when you go for a bronchoscopy, you see everything. Oh my God, there is a connection. So I will have to write that this is a tracheoesophageal fistula. Now, what you can do, you can put a plug. You can put a silicone plug here and seal it transiently or temporarily. Or if not possible at all, you can inflate a catheter. Here. Yes or no? You can even take a Foley's catheter. Now you will say, sir, life of the patient is more important here. You can put a catheter and inflate the bulb, or you can put a silicone bulb here. At least why? So that once this is done, yeah, you can put the patient on endotracheal intubation and start with the ventilation. Yes or no? So yes, you can do a plugging. You can plug it. You can plug the defect. And not only you can plug the defect, also you can inflate a catheter bulb. And then after this, you can do a endotracheal intubation. Students, is this point clear or no? Therefore, early bag mask ventilation is absolutely contraindicated. Sir, why is accumulation what? Prince, what? Why is what? Prince Zuko, I'm not getting your question. Why is air accumulating inside the stomach? Bache, the most common type is the type C. Now, how will the air enter inside the stomach? Because your respiratory system is taking in air from the outside. That air which is going into the lungs is also passed into the stomach. That is why air is going inside. And it is accumulating and getting distended. Now, what is the management? Let us talk about the management also. This is very simple and straightforward. When we talk about the management, now management depends upon, the management is surgical. But see, the problem is not with the surgeon. The surgeons are so noble that they have never killed any patient. It is who kills the patient? Anesthetist. Jokes apart. वो कहते हैं कि कभी anesthetist ने patient नहीं मारा, कौन मारता है? Surgeon मारता है. वो, this is always Tom and Jerry like game which is happening between us. But try to understand, when you are planning for surgery, the first question is the patient fit for surgery or no? Is the patient fit for surgery? And therefore, the cardiac fitness is the most important aspect of this. So what is the most important prognostic factor? The most important prognostic factor is presence of cardiac anomaly. So presence of cardiac anomaly. Is that clear? No? Presence of cardiac anomaly. This is very important. If a patient is having cardiac anomaly, the patient is not fit to withstand GA. वैसे भी the newborn lungs are not fit to undergo for anesthesia, and on that it really becomes difficult. So what are the factors which helps us to decide that what surgery are we going to plan? There are two criteria which we use. One is Waterston criteria. This is the older criteria. Abhi we are not using this criteria. Waterston we are not using. What we are using, students, we are using the modified version, modified splits criteria. Modified splits criteria. Let us talk about this modified splits criteria. What are the parameters that you are going to look at? So on one side we will have the parameters. On one side we have the parameters, and on one side we have the intervention. And based upon the splits, we are going to decide a lot of things. Try to understand that, students. Try to understand. Let us see this thing. So parameters, the first parameter is birth weight. The second problem is cardiac anomalies, presence or absence of cardiac anomalies. Let us decide. If the birth weight is more than 1.5 plus there is no cardiac anomaly, more than 97% chance of survival, more than 97% chance of survival. So I'll write it here. Yeah. So prognosis, I'm talking about prognosis. So more than 97% survival, and therefore definite surgery is the intervention. Definite surgery is the intervention. Let us move forward. If the birth weight is less than 1.5 kg, or there is presence of cardiac anomaly, less than 57% chances of survival, and therefore yeah, you may take the risk of definite surgery. You may take acceptable risk, but you can go. If the birth weight is less than 1.5 kg plus there is cardiac anomaly, less than 27% risk of survival, and therefore you have to go for feeding gastrostomy. Are you getting this or no? Are you getting the intervention? Let us try to understand it in a very simplified form. This is a very easy chapter, and I've seen lot of students mugging up this chapter. Mugging, nahi karna hai. It's very easy. Now, what is the intervention? Let us talk about this intervention also. Intervention is also very simple. Bachche, excision of fistula, and not only there is excision of the fistula, plus also end-to-end esophagostomy. Esophagostomy. So you're getting this? Let us try to understand. This is very simple and straightforward. So if this is the case, imagine this is the case scenario we are having. So the first job that you have to do is you have to excise the fistula. And repair this defect. So you have repaired this defect, and here is your stomach now. And then what is the next thing that you have to do? You have to do the end-to-end esophagostomy. This is what is the most simple management. This is the management for TEF. Is that clear or no? And for esophageal atresia, you have two things. If the edges can be approximated, whenever you have esophageal atresia, the next question is, can edges, but what is this surgery also known as? This surgery is also known as Cameron Hat's surgery. Cameron Hat's surgery. So Cameron Hat surgery is another name for this, lesser known name. So when you have a patient of esophageal atresia, the next question is, can we approximate the edges? Can we approximate the ends? What is this idiotic question? Can we approximate the ends? बच्चे अगर esophagus के दो ends, if you're talking about the two ends of esophagus, the gap between them is really very important. The gap between them is really very important. So that gap needs to be fulfilled. Yeah. Try to understand this. Try to understand. So gap needs to be fulfilled. So can we approximate the ends? If the answer is yes, then you will go for end-to-end esophagostomy. Esophagostomy. Are you getting this or no? If the answer to your question is no, we cannot. There are a lot of options. One is a Forker's procedure. What is a Forker's procedure? What you do, if this is one end of esophagus, if this is the another end of the esophagus, and this is the mediastinum, yeah, this is the baby, yeah, this is the mediastinum that you are having, you'll bring this end out, and then what you will do, sequential tightening of these edges. Yeah, so sequential tightening. What will happen when you do sequential periodic tightening? The edges will get stretched off, and a time will come when they will be sufficiently close. So after 6 to 8 weeks, you'll see it is sufficient to bring them. So sequential periodic tightening is what is actually required. And yes, once they come close, you can always go for. So when they oppose each other, after this, you can always go for this. Is this clear to everyone or no? So what I have decided, every day at this 10 p.m. I'm going to take a small session for you. We'll have small crisp discussion, and do join Unacademy, because this is just the tip. I will not say even tip. This is this much part of the iceberg. Yeah. So use the code surgery live. And join Academy. You can use this code surgery live, and you can access to my special class. You can also join the plus course. Actually, in plus course we have a lot of student customized courses, and you'll just enjoy, because we have a lot of topics going on, a vast and a very elaborate experience for the students, and we have a lot of things for you. So this is just a demo. Actual content is there in the plus, so you can use the code surgery live, or you can also use the code Dr Dixit. So any of the code you can use to join and get some extra discount. So do recommend Unacademy to your friends, and yes, you can talk to your seniors. They have been a part of Unacademy and they have really performed well. You can take the experience, you can take the feedbacks from them. We have been constantly delivering the quality content to you all. So till then, bye bye. I hope you people enjoyed this session.